comes down. Now you can see here on this side, this is perfect. But on the other hand, this side, the upper eyelid has come down and is covering the pupil. Normally, the eyelids don't cover the pupil. So drooping of the upper lid that covers to more than 2 millimeter of superior cornea or some part of the pupil, it depends on the severity of ptosis. It's unilateral in majority of the patients. So then it is usually the local issue. Suppose there is a viral 6-nerve palsy or there is a diabetic ophthalmoplegia, it will be unilateral. Subarachnoid hemorrhage aneurysmal bleed is also likely to be unilateral. Maybe due to hypoplasia or dystrophy of levator palpebrae superioris. Suppose there is a cicatrix of the upper eyelid. So it may appear down and which may indicate it is ptosis, but it is not of neurological origin. Elevation of the upper lid is largely a function of the levator palpebrae superioris assisted by frontal belly of fronto-occipitalis and Mueller muscle. So this one I will come when is seen. You see a surprise look in some extrapyramidal syndromes like progressive supranuclear palsy. Now this is the classification for ptosis. Margin reflex distance 1 is measured from the corneal light reflex to the central portion of the upper eyelid. Or margin reflex distance 2 is the distance from the corneal reflex to the lower eyelid margin. So 1 for the upper eyelid, 1 for the lower eyelid. Now, I will not go in too much of detail because you are not a neuro-ophthalmologist. I have customized my needs or presentation, what is required at MD level or maybe DM neurology level. That's why I asked one of my resident, Dr. Nishant Tomar. We sat together and made this presentation that how he will like to know about the presentation. So what a resident expects from the teacher, like teacher evaluation, he did for me, and this is what is given. If it is mild, less than 2 millimeter, moderate 3 to 4 millimeter, severe 4 millimeter. So suppose this is the eyelid and it comes down like this. How much it covers the pupil, according to that is the classification. Now, causes of eyelid ptosis. We know pseudotosis, Horner syndrome. That's usually there is a ptosis, there is meiosis. Because it is a sympathetic system, sympathetic component to the LPS which gets affected, and then the cholinergic dominates in the pupil and it becomes narrow. So sympathetic, remember one thing, if there is a neck trauma, there is a lesion in the brain, it can be contralateral hemiplegia, but Horner will by and large be unilateral. So remember always that. In midbrain syndromes, this side Horner syndrome because of infarct on this side, but contralateral hemiplegia. The others are like traumatic injury, which is local scarring, I said, because of ocular causes. Or if somebody has gone cataract surgery or something, then also ptosis can be there. Myogenic, because of mitochondrial cytopathy, myasthenia gravis, progressive external ophthalmoplegia, which occurs in CEO, what we call, in mitochondrial cytopathies. Now, when the eye movement happens, there are a number of muscles, there are a number of junctions which are helping us. Suppose we first take nerve, third nerve, fourth nerve, sixth nerve, coming from the brain in the extraaxial space. Then it comes and innervates the muscle. That's neuromuscular junction, like this. That is classical, like myasthenia gravis mentioned all here. Myasthenia gravis or myasthenia gravis-like syndrome, like in Lambert-Eaton syndrome, or botulism toxic. Similarly, muscle can be neurodegenerative, chronic progressive external ophthalmoplegia, oculopharyngeal muscular dystrophy, or myotonic dystrophy, in which both the eyes may look small. But a very good catch for the PGs, if you see baldness with that, or if you see sternocleidomastoid or wasted, there is one diagnosis, that's myotonic dystrophy. Now, clinical examination of the eyelids. Look from a distance. Don't go and touch the patient. Don't rush for looking at the MRIs. First, make a clinical diagnosis from your natural intelligence. Palpebral fissure asymmetry, there can be some physiological, but if it looks pathological and patient complains, then you have to see. Then upper and lower eyelid positioning or lid retraction and scleral show. Then on this side, cornea is less compared to the other side, visibility, then it is ptosis. Proptosis, and I know MD students are very familiar with thyrotoxicosis or Graves' disease, in which it may be protruding eye, but it can also occur in cavernous sinus thrombosis. There is a push from the back, so eye comes on the front. So that is called proptosis. Anophthalmosis, inward or sunken eye. One entity I just mentioned, Horner syndrome. It can also be like some anophthalmosis, or if there is a phthisis setting in, then also the eye may become small because of loss of fibrofatty tissue. Now, this continued. If there is a local eyelid edema, chances are it's more of a ocular cause. If the blink rate is reduced, normal is around 18 times, it's not hard and fast rule. It can be 15 to 20 times per minute. If it is reduced, may indicate either person is depressed or has extrapyramidal syndrome. Now, assess lid position in different gazes. That can help you. If ptosis is present, assess for worsening with prolonged upgaze, which may indicate what? Myasthenia gravis. Because when we are exerting, we are using our acetylcholine quanta at the neuromuscular junction. If they get exhausted, then it will further droop from, like I show you one. I'll remove my glasses and show this. It becomes like sunset sign. It may indicate it is myasthenia gravis. And look for, observe gentle and forced lid closure will indicate how is orbicularis oculi behaving, which may indicate seventh nerve component, either muscle or the nerve. Now, pupil abnormality, as I said, whether it is small or large, it is reacting or not reacting, can be very helpful. Now, lid abnormality associated with cerebral hemispherical lesions. This is from the Bible of Neurology these days called Bradley's. Unilateral ptosis, and what is the likely possibility? Now, it's written contralateral hemispheric lesion. As I said, right side lesion may cause Horner syndrome, right side ptosis, and opposite side hemiplegia. Bilateral ptosis can occur in frontal lobe lesion or bihemispherical lesion. Suppose there is a midline lesion, it is pressing the midbrain, then it can cause bilateral ptosis. Or bilateral ptosis without any brain changes or brain signs may indicate myasthenia gravis. Now, impairment of voluntary eyelid opening and closure can occur in basal ganglia disease or what is called eyelid apraxia. Similarly, you should closely observe this. Some you can read on the slides. Without that, you cannot make a clinical diagnosis. First, a clinical diagnosis, localization, and then proceed with the customized investigations. Now, look at this gentleman. Now, he came in our emergency room with blurring of vision, marked vertigo, vomiting. This triad in a person of this age indicates vertebrobasilar insufficiency. And you see the eyes are being tested by the resident. And now you see here, there is a infarct here in the occipital region. Then he had homonymous heminopia. It's on the right, so he had left side. So initial history is very important to say. He has vertebrobasilar insufficiency, which is equivalent of TIA, or angina, we talk in the cardiac parlance. So this settled into posterior circulation stroke. Now, ocular movements, again to find out, is it upper motor neuron? Is it lower motor neuron? Upper motor neuron usually don't cause double vision. Usually, I am saying, there is no hard and fast rule. Now, conjugate movement supranuclear. Now, saccades fast, 800 degree per second, very fast. This is saccade movement. This is where you should around 12 inches away from your nose or from the midline. Pursue slow following movements, 70 degree per second. These are the pursuits. So they can be broken in number of conditions, especially extrapyramidal syndrome and cerebellar. Now, is it horizontal or vertical? Vertical, we know classically in progressive supranuclear palsy, and or maybe in Harrison or other medicine book you must have read Steele-Richardson-Olszewski syndrome. Lower motor neuron, nuclear or infranuclear. This you should carefully differentiate. Now, suppose there is a infranuclear facial palsy on the right side, and there is a left side hemiplegia. Where is the lesion? It's in the pons, lower part, where the facial nerve is not supranuclear. If it's in the midbrain, it will be on the same side. So this will indicate Millard-Gubler syndrome, neuromuscular junction myasthenia gravis, primary muscle disease, or number of ocular myopathies which can occur as a syndrome or even alone, like chronic progressive external ophthalmoplegia, which is called in mitochondrial syndrome.